So advanced heart failure and mechanical circulatory support devices. And what is heart failure is the best question that we can start with. Is it a low LVEF or is it like heart failure symptoms? It's truly a single, it's not a pathological diagnosis, it's a clinical syndrome. It has to have signs and symptoms along with structural and functional abnormality of the heart based on an echocardiogram or right heart catheterization. The common signs and symptoms of heart failure are breathlessness, ankle swelling, and fatigue are common symptoms. And signs are elevated JVP, pulmonary crackles, peripheral edema are most important symptoms of it. And that is the definition by ESC. And the Heart Failure Society also has a very similar definition. The main difference between ESC definition and the Heart Failure Society of America definition is exercise. Even if you have a signs and symptoms during exercise, if you are at rest normal, and it is still a heart failure based on ESC definition. So lots of people we might have resting, we don't have any symptoms, and they have problem in exercise. So that's still a heart failure. And why do we care about heart failure? In 2012, American Heart Association estimates a direct cost of $3,600 and $1,700 indirect cost per patient year. And by 2030, nearly $70 billion per year is specifically for heart failure diagnosis. What it roughly means is roughly $245 per every US adult is paying for the heart failure diagnosis. And in United States, there are 5.7 million of adults who are diagnosed with heart failure, and the estimated annual direct cost is $39.2 billion to $60 billion. And in 2020 fiscal year, 83% of Medicare participating hospitals were penalized for a total of $563 million. And that's one of the reasons why most of the cardiologists and heart failure people and hospitals are going behind heart failure readmissions just because it's $563 million. Then we will look at it where this cost of healthcare is going. Is it an inpatient setting or is it the medication? And we hear lots of things about it. Nearly 50%, 49% is for an inpatient cost care. Medications are only costing 8% out of entire heart failure expenditure that we are doing. Outpatient care is costing roughly around 28%. So this is the economical impact of heart failure on our US healthcare. How do we classify the heart failure? Can we classify based on an LVEF? We can classify based on the disease etiology. If you are going to classify based on an LVEF, it is going to be less than 40, 40 to 50, and greater than 50. If you have greater than 50, we will call that as a HFpEF. If it is less than 40, we will call that as a HFrEF. Between 41 to 50% of LVEF, we would call them as heart failure with mid-range ejection fraction. For all these things, we should and must have signs and symptoms of heart failure in order to call as a heart failure. Otherwise, it would be purely called as a cardiomyopathy. And then we can classify it based on etiology. Is it an ischemic cardiomyopathy or non-ischemic cardiomyopathy, or is it a gene-based cardiomyopathy? For example, there are some people who have a lamin gene mutation and tinnin gene mutation. They can develop into a low EF, or hemochromatosis, or left ventricular non-compaction. These are all come under the umbrella of genetic cardiomyopathy. And then there is a peripartum cardiomyopathy, stress-induced cardiomyopathy. Nearly 1/3 of the cases, we will try to do everything. We still can't find exact etiology, then we will call them as idiopathic dilated cardiomyopathy. If you are going to see few of my notes, or like, if there are two things when we are trying to evaluate a heart failure patient. One is staging, and another one is like a heart failure symptoms. Stage A means patients are at a higher risk for heart failure, like people who have a hypertension, but they did not develop cardiomyopathy, diabetes mellitus patients, and people who are receiving chemotherapy, and people who have a genes that can cause cardiomyopathy, but they did not have a cardiomyopathy yet. And number two, they have stage B. These are the people who already have a drop in ejection fraction, but did not have a heart failure symptoms. And stage C is the people who have a symptomatic heart failure patients. And stage D is they have a significant refractory heart failure symptoms, or they need to depend on mechanical circulatory support devices like LVAD, or they are getting evaluated for transplants or inotropic support. And then we will have an NYHA class symptom classifications. Class 1, there is no limitation of physical activity. Ordinary physical activity does not cause any shortness of breath. And stage 2, NYHA class 2 means there is slight limitation of physical activity. And status 3 is marked limitation of physical activity, comfortable at rest, but they cannot do usual daily activities without having trouble breathing. And NYHA class 4 symptoms are people who have a shortness of breath at rest, and any physical activity can cause further discomfort. And then we have another way of looking at the heart failure, that is new onset heart failure, and heart failure people with resolution of the symptoms, and people who have a persistent heart failure symptoms, and people who can have worsening of heart failure signs and symptoms. What is the role of ejection fraction? And everyone loves to have echocardiogram, and it would help us to classify whether they belong to heart failure with reduced ejection fraction, or a mid-range ejection fraction, or heart failure with preserved ejection fraction. And also it helps you to have a prognostication. Like if people have an LVEF less than 25%, they are at a higher risk for mortality. But heart failure with preserved ejection fraction, people have a similar mortality as if heart failure with reduced ejection fraction. And we also need to understand LVEF is a dynamic feature. It depends on preload, it depends on afterload, and it depends on inotropy. For example, if the patient is on milrinone, and if I do an echocardiogram, I might have a normal LVEF, but as soon as I turn off the milrinone, they would have a drop in ejection fraction. And then common question is, how often we need to do echocardiogram? We can do echocardiogram as long as there is a clinical change in the patient condition. We don't need to do an yearly echocardiogram, or we don't need to do a 6 months echocardiogram to evaluate how the patient is doing. We will do it if the patient clinical status changes. And also, like, if you have a low EF patient, and after 3 months, we will do it to evaluate whether they will need an ICD or not. And common thing that we forgot about is physical exam and biomarkers. And what are the most important physical exam findings? Is it Rales, or is it ascites? Is it an edema? To evaluate and tell us whether the patient is having wedge pressure greater than 25. In this study, the most reproducible and sensitive and specific marker is elevated JBP. JBP greater than 12 mmHg is a very good marker that the patient has a wedge pressure greater than 23. And S3 gallop is also a very good prognostic indication. And why the physical exam is important? Then we can do 2x2 classification. This is called Stevenson classification. And we can grade these people into hot and dry, hot and wet, cold and wet, and cold and dry. Why it is important? People with a cold and dry of this 2 by 2 classification has a very high mortality. And these are the people who needs a very good care and need to have a very close follow-up to evaluate for when they need for advanced heart failure therapies. And then JBP exam, this is the way that we will do JBP exam. We will make them to sit at 45 degrees angle and we'll check JBP from manubrium sterni to the height of observer jugular venous pulsation. Sensitivity is around 65%, specificity is around 64%. And then we have another thing called proportional pulse pressure. It is the difference between the systolic and diastolic blood pressure and divided by your diastolic blood pressure. And it can tell us roughly what is approximate stroke volume could be in this patient. Around 25%, people will have poorer outcomes if proportional pulse pressure is greater than 25. And Valsalva maneuver, and as we all know, Valsalva maneuver has 4 stages. At the onset of Valsalva maneuver, we will have an increase in blood pressure, and then we will have a nice drop in during the maintenance phase. And once we release it, then we will have a overshoot. In people with heart failure, we will have either square root phenomena or they never will have a overshoot of the blood pressure. Why it is important? Valsalva maneuver tells you more about your LV filling pressures and also how low is LVEF is. And JVP tells you more about your right-sided filling pressures. In 1/3 of the cases, JVP would not correlate with your LVEDP. And we all like to know about the utility of a BNP. BNP is useful in diagnosing it, and it is always important to have a BNP at the time of discharge to see whether we have appropriately decongested the patient or not. And it will also help us to track it as an outpatient once a while to check it to see whether it made any difference. And then we have a cardiopulmonary exercise test, and that we do quite often. And if MVO2 levels are less than 14, we will have a mortality rate greater than 20% per year. That's the reason why we use cardiopulmonary exercise test, and 14 as a cutoff point for doing orthotopic heart transplants or LVADs. If people cannot reach MVO2, VEV-CO2 slope is also a surrogate marker. If VEV-CO2 slope is greater than 35%, they are at a higher risk for mortality. And when we are also performing cardiopulmonary exercise test, we want to see what is the heart rate response, what is the heart rate recovery. And these are all important features that we are going to get from a cardiopulmonary exercise test. And then very brief note about heart failure with preserved ejection fraction. People with heart failure with preserved ejection fraction also sometimes need advanced heart failure therapies. And people also need to be evaluated for other etiologies. Common etiologies for heart failure with preserved ejection fraction are cardiac amyloidosis or hypertrophic cardiomyopathy or renal failure and storage disorders are the common etiologies that we need to rule out before we label them as bread and butter heart failure with preserved ejection fraction. And then we will go briefly about medical management for stage C and D heart failure. So most of the drugs like ACE inhibitors and ARBs and MRA have a mortality benefit. Number needed to treat in these trials are for ACE inhibitor in SOLVE trial is around 18. Beta blocker trials were on the top of ACE inhibitors, and they have a number needed to treat in MERIT-HF trial is around 8. And cardiac resynchronization therapy trial, RAFT trial, number needed to treat is around 14. And the latest like medication, Arni and Entresto, has a number needed to treat is around 11 when compared to imputed placebo and 21 when compared to enalapril. And ICD therapies, we will have a number needed to treat 14. And then we have new medication called SGLT2 inhibitors came into the role, and we all prescribe it. And other than DAPA-HF trial, most of other SGLT2 trial inhibitors showed a heart failure readmission benefit, and DAPA-HF is the only trial that showed some mortality benefit. And other medications that you guys might see once a while is about bidal combination. It is based on a trial called AHEFT trial. It has a mortality benefit. In order to prescribe a bidal combination in this trial, people identified themselves as African Americans before they enter into the trial. And heart failure hospitalization benefit is 16.4 versus 24.4%. And we use once a while like ivabradine based on SHIFT trial, and it is mostly about heart failure hospitalization benefits. There is no mortality benefit. Then we will use digoxin most of them, and this is based on a DIG trial, and it is also heart failure hospitalization benefit. If we are planning to use digoxin, we will try to use a therapeutic range anywhere between 0.8 to 1.2 nanograms per deciliter. And omecamtiv mecarbil, some of you guys might have heard about it. It is based on a galactic HF trial, and it is also heart failure hospitalization benefit. Varosugvat is also based on a Victoria trial. It is also about heart failure hospitalization benefit. Almost all of these trials excluded people who have a stage D cardiomyopathy and NYHA class 4 symptoms. And mortality benefit in stage D cardiomyopathy is uncertain. And we also need to think about device therapies that would change the outcomes. And defibrillators decrease the mortality, and cardiac resynchronization therapy decrease the mortality. But defibrillators does not change your LVEF. Cardiac resynchronization therapy could change your LVEF. And that's a place where we want to look whether we are having a mortality benefit versus a morbidity benefit. MTR, mitral clip, the number needed to treat is around 6. And sometimes we use this as a bridge to advanced heart failure therapies. And we also need to think about what is the average age in these trials is. Most of the defibrillator trials have an average age less than 75 years. And it is always important to have a shared decision making with the patient. Patient must be aware of what we are doing and why we are doing. And we also believe on the fact that it has to be a team-based approach. Team does not mean heart failure cardiologist or a general cardiologist. Team includes the patient, primary cardiologist, and internal medicine doctor or a family medicine doctor. And if the patient is in critical care, pulmonary critical care team. And it is a team approach that makes better outcomes than any individual division approach. Now we will change it to gears a little bit. So we will talk more about cardiogenic shock. What is the definition of a shock, cardiogenic shock? We all talk about it. What are the definitions that people used in different trials? In shock trial, they used a systolic blood pressure less than 90. And in intra-aortic balloon pump SOAP 2 trial, we used a MAP less than 70 or systolic blood pressure less than 100. And EHS-PCI trial, they used a systolic blood pressure less than 90. And ESC guidelines, they used systolic blood pressure less than 90. And NIH trial also, it is around systolic blood pressure less than 90. And it should be lasting more than 30 minutes. And also you should have a drop in urine output. If they have a Swan-Ganz catheter, they should have either cardiac index less than 2.2 ml per kg per minute or wedge pressure greater than 15 in order to diagnose with cardiogenic shock. And these are the stages of cardiogenic shock. People who are at a higher risk for having cardiogenic shock is stage A. And in the beginning of cardiogenic shock, it is stage B. and progressing classic cardiogenic shock is stage C, and deteriorating is stage D, and extremes is stage E. Why we need to classify the cardiogenic shock? Why can't we use a single label? The reason for that is mortality rate is different between these stages. People who are at a higher risk, they have a mortality rate less than 5% in either ICU or in hospital mortality. People who are at a stage G, the mortality rate is close to 70% in hospital mortality and greater than 55% in ICU. So that's the reason why it is important to identify shock at an early stage and treat it aggressively so we could decrease the mortality, both in-house mortality and ICU mortality. And how do we identify who are at a stage A and stage B and stage C? It is mostly either by cardiac index or PA saturations. And stage C people who have a cardiac index less than 2.2 and a wedge pressure greater than 15 mmHg, PAPI less than 1.85, cardiac power output less than 0.6, and they will start having elevated lactic acid levels. And they will have a worsening of GFR, and that's the pretty much like defines classic cardiogenic shock. Stage B people have a cardiac index still greater than 2.2, but their heart rate is high to counteract low output and index. But they still have normal renal function and lactic acid levels, but just an elevated BNP. And there is a clinical evidence of hypotension and tachycardia without symptoms. Obviously, if people are having stage G, they will have a low pH, and at that moment in time, we might need to worry about advanced mechanical circulatory support devices. Does the temporary MCS trials, all of them showed a very good mortality benefit? Answer is no. And it depends on all the trials that we look at. And most of the trials did not show any major mortality benefit other than Impella trial. And these are the trials that were done on balloon pump. And VA ECMO, as we all know, that mortality rate is close to 50%. And by the time we are talking about VA ECMO, we are talking stage D and G. And it also depends on how early we identified the people to be in cardiogenic shock. Things to consider in cardiogenic shock. Not all cardiogenic shocks are same. Is it an RV dominant shock, or is it a biventricular shock, or is it an LV dominant shock? And why it is important? The way that we choose the mechanical circulatory support devices is different between these two. People who have an RV dominant shock, we will think about just a right ventricular support with the Protect Juvo or RV Impella. And if they have pure left ventricular dominant shock, we can see whether they can get LV Impella or like an intra-aortic balloon pumps. And if they have a BIV shocks, we are thinking about whether we need any VA ECMO or biventricular support. These are the common devices that we use, and intra-aortic balloon pump is like augments in the diastole and decompresses in the systole. It creates a wind cycle phenomena, and it increases the coronary perfusion, and it on an average provides a 0.5 to 1 liter at the most extra cardiac output. In order for your intra-aortic balloon pump to work, patient should have a reasonable LV contractility. And if LV is completely down, it may or may not change it. And it might increase your MAP. And the cannula size that we use for intra-aortic balloon pump is anywhere between 7 to 9 French cannula. And then we have an Impella, and which is temporary percutaneous LVAD. We will Impeller is located in the LV and takes the blood from LV and pushes into the aorta, and it decreases the LV filling pressures. And we generally use anywhere between 13 to 22 French based on what is the Impella we are using, whether we are using Impella CP versus Impella 5.5. Impella 5.5 is always within a surgical technique, and Impella CP can be percutaneous through the groin. It decreases the LV unloading. It also increases the coronary perfusion pressure. And then we have a tandem heart where we go through the intraatrial septum and drain from intraatrial septum and push the blood into the aorta. And it is a centrifugal pump, and it can give almost up to 4 to 5 liters of cardiac output. And it is not going to improve the coronary perfusion. In fact, it may decrease the coronary perfusion, but it will avoid using venting mechanism for LV. This is VA ECMO. We can do from 4 to 10 liters, and it provides a biventricular pressure and volume unloading, and also peripheral resistance will increase significantly. And the cannula size is going to be drainage cannula is around 18 to 21 French. Return cannula is around 15 to 22 French. Why the cannula sizes are important? Because as we increase the cannula size, the peripheral complications is going to go higher and higher, like limb ischemia, bleeding, and that's the reason why the cannula sizes were mentioned during this talk. Contraindications, generally we do not do VA ECMO or tandem heart unless we are thinking that the patient has exit strategy. And then we use intravenous inotropic agents all the time. Why do we choose sometimes dobutamine, like melronone, epinephrine, and norepinephrine? And what I did not mention anything about vasopressin here because that's purely a peripheral vasoconstrictor more than anything else. Dobutamine is generally we use it between 2.5 to 20. For most of the heart failure, we don't go above 7.5, max of maybe 10 at the most, and the average half-life of the dobutamine is 2 to 3 minutes. It increases the cardiac output, increases the heart rate, and it is neutral on systemic vascular resistance, and it is also neutral on peripheral vascular resistance. Milrinone is 0.125 to 0.75. Generally, we don't go above 0.375 as complication rate goes higher, and the half-life of milrinone is around 2.5 hours. It drops your systemic vascular resistance, and it also drops your peripheral pulmonary vascular resistance. And so that's one of the important reasons why we choose between dobutamine and versus milrinone. Epinephrine is also acts on your alpha beta receptors, and it increases your at very low doses, it drops your systemic vascular resistance as you are increasing the dose of epinephrine, and you will increase the systemic vascular resistance, and it is very neutral on your pulmonary vascular resistance. And norepinephrine is clearly increases your systemic vascular resistance, neutral on your pulmonary vascular resistance. And when we are doing a VA ECMO, we have are we doing it for a bridge to decision? We don't know this patient. Patient came in for a cardiogenic shock. Now I need to make a decision, and I want some time whether this patient needs LVAD or advanced heart failure therapies. That's called bridge to decision. And bridge to candidacy is also like, we use ECMO as a method to get them to an LVAD. Bridge to transplant, and they will go for a status 1. They get transplants very quickly. And bridge to recovery, we use it once a while, and it explains clearly. We are doing VA ECMO, hoping that their LV recovers. Switching gears from temporary MCS to durable mechanical circulatory support devices. And indications for advanced heart failure therapies, generally, we should have an NYCHEC class 3 or 4 symptoms, and they should have an LVE of less than 30%. And sometimes we do advanced heart failure therapies for isolated RV failure, like ARVC, and patient like having severe non-operable valvular abnormalities or congenital abnormalities and persistently high BNPs. And if the patient is requiring low inotropic supporting agents for keeping low cardiac output, and also patient has a severe impairment of exercise capacity. This is the place where I was talking about cardiopulmonary exercise test is an important criteria. But at the same time, if we cannot do a cardiopulmonary exercise test, we can do a 6-minute walk distance in the clinic. If a person cannot walk more than 300 meters, they are having NYHA class 3 symptoms at least. So we need to be very careful about it. And patient meets the criteria from 1 to 4 with a cardiac dysfunction is the reason why we need to do an advanced heart failure therapy evaluations. We can have a modifiers like an arrhythmia. We can do a LVADs for people who have an ventricular tachycardia or refractory ventricular tachycardia. And we can have a higher UNO status if patient is having requiring IV amiodarone for a ventricular tachycardia and still having VT, they can get a higher status from UNOS. And then we have an intermax profile, and profile 1 means critical cardiogenic shock patients. They are crashing and burning. And the profile 2 is progressive decline. They are declining and they are requiring inotropic supporting agents. We are increasing the inotropic supporting agents. They are having worsening of the renal functions. And profile 3 is stable, but they still require inotrope. These are the people who are having home inotropes with the dobutamine or melatonin. And profile 4 is resting symptoms. Why we classify them? Then profile 5 is exercise intolerant, and profile 6 is exertion limited, and profile 7 is advanced NYHA class 3 symptoms. Why these profiles are really important? The mortality rate is going to be different between different profiles. If people are at profile 4, they have a very less mortality, and profile 1 has a very high post-transplant mortality, post-LVAD mortality. That's the reason we want to identify the people at Intermax profile 4 and 3, and so they would have a better outcome. So mnemonic for advanced heart failure therapy referrals. If anyone is requiring inotropes, they need a heart failure referral. And NYHA class 3 and 4 symptoms with a persistently elevated BNP, they require a heart failure consult. And if they are having end organ dysfunction, like worsening of renal function or liver function, and they should have an ejection fraction less than 20, they require an advanced heart failure therapies. Or if the patient is requiring multiple shocks, if the patient is having more and more VT, that includes ATP therapy. And it's not just ICD shocks. If the patient is having more VT and requiring ATP therapy, then they should be evaluated by heart failure cardiologists. And if the patient is having edema that is requiring a higher dose of diuretics, or we are having blood pressure issues, or we need to take off guideline-directed heart failure medical management like ACE inhibitors, if we are needing to decrease the dose, then they need heart failure referral in a way that came as I need help. That's what the mnemonic for referral is. And what are the advanced heart failure therapies when you guys refer the patient to us? We look at it. Are they candidate for a transplant? Are they candidate for LVAD? Are they candidate for total artificial heart or palliative care? And those are the 4 options that I would look at it. And this tells us like how we organize ourselves with regards to which how quickly I need to take to the people for an advanced heart failure therapies, and also like how I operate. And if the people are having Intermax 3 and 4, and if there is a contraindication for a heart transplant, and is it a potentially reversible? Can I do an LVAD bridge to candidacy? And if there is a contraindication, then do I need to take for like delisting and go from there? Obviously, what are the contraindications? Still, the gold standard treatment for advanced heart failure therapy at this moment in time is orthotopic heart transplant. And contraindications are if the patient is having active infections or severe peripheral arterial disease, high PVR. If the PVR is greater than 5, that is non-reversible, then they cannot get a heart transplant. And we also worry about irreversible liver dysfunction or irreversible renal dysfunction unless I can do a heart and kidney or heart and liver transplant, or if the patient is having malignancy or active malignancy, are the main reasons why we cannot do orthotopic heart transplant. And another serious comorbidity that decreases the prognosis. BMI is is a sketchier area. Each program has their own cutoff BMI. On an average, BMI greater than 35 is cutoff, but sometimes these guys come with so much volume overload. If we diurese them, their BMI get down from 38 to 35, and they might be getting a transplant candidate. And if they are current alcohol drug users, we can do the transplant. And if the patient has a psychological inability. One of the most important contraindication we underestimate is insufficient social support. And LVAD is another uh, uh, advanced heart failure therapy option. We look at it if the patient has a less than 25% EF and more than 3 heart failure hospitalization in 12 months without an obvious precipitating cause, or if the patient is requiring IV inotropic therapy, I would look at LVAD as a great option for them. And contraindications, obviously the age and renal failure, because the risk of infection goes significantly high if you are doing a dialysis on an LVAD patient. So that's a reason. And some people end up with an end-stage dialysis after LVAD, but we do not want to do an LVAD if we know that the patient is going to have an end-stage renal disease. RV failure is another major risk factor why we cannot do the LVAD. And if people are having RV failure at baseline, we don't do LVADs. But sometimes we try to optimize their LV function because nearly 30% of your RV function comes from your LV function. So once we optimize, and we will reevaluate with PAPI, and which is the right heart cath parameter, and what is their CVP is, and how is the liver doing, and we will try to evaluate whether RV can handle LVAD or not. And if there is all the LVAD patient require uh, anticoagulation with Coumadin, and if there is any contraindication for anticoagulation, we cannot do the LVAD. Obviously, family support and social issues. Total artificial heart, if patient has a BIV failure and I cannot do transplant at this moment in time, it is an option. I can do it as a bridge to transplant. Contraindication, if I cannot do a transplant for any reason, we cannot do a total artificial heart. And issues specific to our healthcare system, we are not an LVAD center or an orthotopic heart transplant center. We refer our patients to University of Utah, and we are working towards an LVAD center as a destination therapy center. When to call heart failure consult is the another question. Is we are here, and any concerns or issues, please call us. We are available, and we are there for you guys. And anything that you guys are in doubt, please call us. We can also use that I need help mnemonic to use that. And if the patient is having low EF and recurrent heart failure admissions, we are more than happy to come and see you guys. And any heart failure with preserved ejection fraction with recurrent admissions, we want to see them because, again, like we saw in the third slide, that every healthcare organization is getting penalized for heart failure readmissions. Thank you. Any questions? Hello?
Anyone have any questions?